Thank you. So hopefully everybody can see my screen right now. Today I am presenting on behalf of the authors that are listed on this slide. I am a first year fellow with the CTN. And in the past 5 years, I've received grants and/or fellowships from the organizations listed on this slide, including, of course, the CTN in conjunction with CanFAR, and the study that I'm describing today received funding through the NIH. So cytomegalovirus, or CMV, is a herpes virus that causes lifelong infection in the majority of adults globally. And it's a particularly important infection in the context of HIV or other immune compromising conditions because it can cause sight or life-threatening disease if CMV is allowed to replicate unchecked. And even in the absence of overt CMV disease, which we see less these days with antiretroviral therapy, even in the absence of that overt disease and after controlling for HIV viral load and CD4 count, there's still a significant association between CMV infection and mortality in people living with HIV. There have been some attempts at creating CMV vaccines, but so far they've had disappointing efficacy. And so what we really need is an improved understanding of natural CMV shedding and transmission dynamics, as this will inform strategies to create a vaccine that is effective. And it's really important that we understand these parameters not only in people without HIV, but also people living with HIV who stand to benefit most from a CMV vaccine. So our objective in this analysis was to characterize CMV shedding in multiple bodily compartments in a cohort of adults living in Uganda and to explore the impact of HIV infection on shedding. So adults who were both male and female and living with and without HIV, aged 18 to 65, were recruited for studies of Kaposi sarcoma, or KS, at the Uganda Cancer Institute in Kampala between 2005 and 2006. In order to be included in the study, the participants had to have a CD4 count of greater than 200. They had to be not taking antiretroviral therapy, which was in accordance with the WHO guidelines at the time. And they also had to be not taking medication with anti-herpes virus activity during the study period. The study period itself was 28 days, and over that time frame, the participants were asked to collect oral swabs daily. They also came in weekly to have physician-collected oral and anogenital swabs, as well as plasma samples. And they had serum collected at the first and the last visit. The DNA was extracted from the mucosal swabs and the plasma samples, and real-time qPCR for CMV was done with both positive and negative controls. And samples were considered positive if they had greater than 150 copies per mil detected in the mucosal swabs or greater than 50 copies per mil in plasma. And so one of the things we were interested in was the rate of mucosal shedding, or viremia, and this was defined as the number of samples with CMV detected divided by the total number of samples collected from an individual. And we compared the rates and quantities of mucosal shedding and viremia between people living with and without HIV using generalized estimating equations models and adjusting for KS status. And the reason we were adjusting for KS status is because this was a predetermined confounder to include in the models. It's known to be associated with mucosal and plasma shedding. There were 85 participants enrolled overall who provided at least one oral swab. About half of those were living with HIV and half were not. And then amongst those two groups, about half of the participants had KS and half didn't. You can see some more details about the cohort on this slide. So among people living with HIV who were enrolled, 33% were female, compared to 43% among people without HIV. The median age was very similar at 31 or 32 years old. Again, about half of these individuals in each group having KS. Among the people living with HIV, the median CD4 count was 439 and the median HIV viral load was 54,000. There was serum available from 83 out of 85 of the participants. And all of these individuals were CMV seropositive. In the 2 individuals who didn't have sera collected, they were orally shedding CMV. And so we know that all of the participants had evidence of CMV infection. So in terms of the rates of CMV detection, CMV was detected orally very frequently. It was detected on at least one day in 71% of people without HIV and 84% of people living with HIV. In terms of looking at all of the swabs together, it was detected in 11% of all oral swabs from people without HIV and 57% of all oral swabs from people living with HIV. The genital site was similar in that we saw this trend of increased detection among people living with HIV, but the rates were lower than what we'd seen at the oral site. And again, when looking at plasma, we saw that same relationship where we're seeing more detection in people living with HIV than those without. And so CMV was detected in plasma on at least one day in 14% of people without HIV and 36% of people living with HIV. And so on the right-hand side of this slide, you can see the rate of detection for each of the sites that we looked at by HIV status. When we looked at the risk of site-specific CMV detection among people living with HIV compared to those without, we found that the risk of CMV oral shedding was 5.2-fold higher in people living with HIV. The risk of genital shedding was 5.6-fold higher, and the risk of viremia was 3.6-fold higher. And these differences were all statistically significant. We then looked at the effect of HIV viral load and CD4 count on the risk of detection among the people living with HIV. And we found that CD4 count was not associated with CMV detection at any site. For each log increase in HIV plasma viral load, that was associated with a 1.4-fold increased risk of CMV oral shedding, which was significant. But HIV viral load was not associated with CMV detection from the blood or genital tract. And then we looked at the quantities of CMV that were detected. So on the left-hand side, you can see the mean difference in quantity shed comparing between people living with HIV and those without. And we found that people living with HIV had statistically significantly greater quantities of CMV detected from the oral mucosa only. Again, on the right, you can see the mean amount shed by site and by HIV status. So overall, we found that CMV oral shedding was very frequent in both people living with and without HIV. CMV detection at the mucosal and plasma sites occurs more frequently in people living with HIV than people without. And we found that there were increased quantities of CMV detected from the oral mucosa of people living with HIV. So this was a comprehensive study of CMV replication and demonstrated that CMV could be detected frequently, particularly in the oral mucosa. And so now we're moving forward in a contemporary cohort to look at the dynamics of CMV transmission between mothers and their infants. And that's because it appears that mothers are most frequently reinfected in pregnancy by young children, and maternal reinfection is the greatest contributor to congenital CMV infection, which causes a huge health burden globally and disproportionately affects infants born to mothers living with HIV, even if HIV isn't transmitted to the infant. And so specifically, we're looking at the genomes of CMV that are transmitted versus those that are not transmitted, and asking what gives those transmitted strains a competitive advantage. And this can also inform, therefore, what strains should be included in a vaccine. And we're also looking at the amount of virus shed below which transmission is unlikely. And so this starts to get at what reduction in viral shedding would be required for a vaccine to be successful, because it may not have to be absolute. I'll just finish by saying thank you to the participants, the study team, and the funders who made this possible. Again, this study was funded by the NIH, and I'm supported through a CANFAR and CTN postdoctoral fellowship.